I can have everyone's attention. Good morning. Thanks for coming out today. I know it's not always easy to get up early at conference. Some of us stayed out later than we might have liked to. I think one of the things that we all can agree upon is that we're having difficulties maintaining access for our patients. Can we all agree upon that? I think that's why most of us are here, and that's why our panel is here. We've heard lots of discussions, and we will, about venous depletion and vein preservation and the failure rate of short peripheral catheters. And our panels today are from Brigham and Women's, the first two ladies, in Boston, and Sarasota from Florida. And we thank you guys for coming. I know it wasn't particularly easy. And today's discussion is about purposefully reducing venous depletion in all patients and an evidence-based approach for adults through the NICU. And I am very pleased to introduce this panel of ladies that are very forward-thinking and trying to find a solution to this very real problem in vascular access. We first have Jess Marchetti, nice Italian name. Jess has been a staff nurse in the NICU since 2001, where she has been dividing her professional time and between vascular access and undertaking the care of critically ill infants. Jess teaches NICUs to the fellows, so kudos to her, that's awesome. She teaches best practices in PICC placement. She's passionate about reducing venous or needle sticks in the NICU patients that she cares for. Nina has 18 years of experience as a NICU nurse. She's the charge nurse and a member of the Clinical Practice Council and resides on the Infection Control Task Force. She has presented before at AVA in Dallas on the development of a successful RN physician PICC team. Nina believes in the importance of vein preservation and has been dedicated to advancing vascular access practices in neonates with the latest techniques. Linda Masoor. Linda is a vascular access nurse with 30 years of nursing experience. She has extensive experience in oncology, critical care, and emergency care. Linda has been passionate about vascular access and has been instrumental in the development of the Extended Dwell Peripheral Program with Mary. Mary Moretti, at the end there, hi Maria. Mary has been a vascular access nurse for 34 years, providing quality care to a variety of patients. Mary was nominated as a Nurse of Excellence. Congratulations on that. Mary is a detail-oriented nurse. She is proactive and self-motivated. She is also passionate about reducing venous depletion. So please help me welcome them. And what we'll do is we'll take questions at the end of the presentation. All right, thank you, Jess.
Good morning. Can everybody hear me okay? So Nina and I are here. We are going to discuss increasing vein preservation in neonates and newborns using the extended dwell peripheral IVs. Financial disclosures, Vygon is sponsoring us to present today, and we will not be discussing any off-label use or investigational use in our presentation. So the first thing we wanted to discuss are what are the types of vascular access devices that we use in our NICU. So the first is what most of us use is a peripheral IV, which is placed at the bedside by an RN. Typically we use a 24 gauge IV in our NICU. An umbilical venous catheter, or UVC, which is placed at the bedside sterilely, typically on day of life 1 by a physician or a neonatal NP. It can remain in dwelling for up to 10 days, although I know that a lot of other facilities do not do that. But the average dwell time in our NICU has been 7 days. A PICC, or peripherally inserted central catheter, can be placed sterilely at the bedside by a trained RN or physician and can remain in place for the entire length of treatment. And then a Broviac, which is placed surgically in the OR and can be in place for the entire length of treatment. So what are some of the complications of using these vascular access devices in the NICU? So a PIV has a very high risk of infiltration, leakage, occlusion, or dislodgement, and has the inability to infuse vital vesicant nutrition or medication for long periods of time. A UVC has the inability, we can have the inability to insert the catheter into proper position. Many times when the physicians are trying to insert this catheter, it tends to track towards the liver, and once it makes that track, it can't be left in place, and they need to pull it. The insertion site is open. It is not we don't typically cover them with a transparent dressing, so it has a higher risk of infection. There is that potential for migration in or out since it isn't open, and sometimes they secure it with sutures, but sometimes the sutures don't actually hold very well. And it can only be indwelling for that short period of time, as stated before, up to 10 days. The PIC sometimes we have the inability to insert the catheter due to vascular depletion or vascular size. We've had patients that weigh, sometimes between 300 and 400 grams, and we just aren't unable to place it due to our device size. There's a high risk of a bloodstream infection, and there is a potential that we place it well, but a mechanical phlebitis develops, and we can't seem to resolve that, so they end up pulling it, thinking that it's some sort of infection. And the Broviac requires a transfer to the OR for insertion. In our facility, we have to transfer to another hospital. We are connected by a bridge, but still, it's a big transport for some infants, especially at 24 weeks. And there is a high risk of infection for the line, just like a PIC. So what we wanted to discuss here today is the use of an additional vascular access device, which is the extended dwell PIV. So this can be used with infants with difficult vascular access who need short-term IV therapy for fluids or medications. It can be placed by a trained RN or a physician at the bedside, and it can typically be placed without sedation. Usually we use a pacifier and swaddling with sucrose, and that has been found really to be effective. Because the catheter is short and the catheter tip does not dwell into the central circulation, an X-ray is not needed for placement verification, and thus that reduces a radiation exposure. It can be replaced for up to 29 days. They come in a lot of various sizes. We typically use between the 4 and 6 centimeters in length. And the catheter material softens after insertion, thus it fully helps with the vessel irritation. So when we first learned about EPIVs, we tried to decide who would be the best candidates for placing these. And the team decided that we would place them in near to full-term infants, so around 35 weeks and up. And that they had a potential diagnosis of needing therapeutic hypothermia treatment, having an infection that required antibiotic therapy for more than 5 days, or infants that were deemed by staff nurses to be difficult vascular access. However, our first patient did not fit into that criteria at all. So I'm just going to go into sort of a case study so you can see what ended up happening. So our first patient was 29 weeks gestation, female that was born at 1,600 grams, way below our 35-week initial thought. A UVC was placed on day of life 1 and then remained in place for that 7 days and removed, and then the PIC line was placed on day of life 7. The PIC line remained in place for 8 days when it was pulled because of positive blood cultures. We were super disappointed by this because we had really spent a lot of time working on decreasing our collapse rates. So we were not very happy to pull this. But we ended up placing a peripheral IV for antibiotic therapy. After 7 days of antibiotic treatment, the infection control team deemed that this patient needed 21 days of antibiotics. And that was because the blood cultures didn't clear for 6 days. This was a pretty significant CLABSI. In that time, the infant was going through about 2 peripheral IVs a day. And so had received around 14 PIVs with multiple stick attempts and was deemed a difficulty for vascular access. Because of those 6 days it took to clear the blood cultures, the medical team really did not want us to place another CVC. So at this point, the vascular access team met and we discussed the possible option with the medical team about utilizing the EPIV after we had heard what the benefits would be. So the EPIV was inserted successfully and it remained in place for 14 days. And it was only removed because we had some leaking at the site. It was not infiltrated, it just was leaking. The infant did require an additional 2 days of antibiotic therapy, and luckily only one peripheral IV was needed. So our analysis of this case study is that the EPIV did decrease the potential of multiple additional PIVs and IV stick attempts over those course of 14 days. If the infant continued on the path of needing 2 IVs a day, there was a potential of this infant requiring 28 additional PIVs for this antibiotic therapy, which is horrifying. We decreased the risk of having another CLABSI because another central line was not needed. And it was placed at the bedside, so we didn't need to transport over to the OR. Some of the negatives that happened was that it did not remain in place for the entire course of treatment, but the infant did only require 1 additional IV, so we found it to be a success, even though it didn't last the entire course of treatment. And it did require a continuous heparinized KVO fluid infusion. So on a neonate, for this patient, that's a lot of fluid. It ended up being about 30 milliliters per kilo per day. So that infant sort of was not able to achieve full feedings, and every day it did factor into the nutrition intake. So after our first patient, we decided, all right, we need to relook at who we're going to insert an EPIV in. So what we decided was that any infant can receive an EPIV if the vessel can support a 2 French catheter size. Any infant that's deemed inadequate vascular access that can support the vessel, who requires antibiotic therapy or IV fluids, but we are unable to place a CVC, so it can be used in the interim while another person tries or we transfer to the OR for more surgical help. And then any infant who requires IV non-vesicant antibiotic or IV nutrition for up to that 29 days. So I just wanted to go through I'm going to go through 3 different patients, just so you can get an idea on the diversity of the EPIV use that we've used in our NICU. So there's going to be some successes and some not so successful. So this patient was 29 weeks and weighed approximately 10-30 grams. A UBC was placed on day of life 1, just like we wanted, but it migrated and it needed to be removed on day of life 3, so a PIC was placed on that day. Unfortunately, the infant had a perforated bowel on day of life 5 and an ileostomy procedure was performed. The infant reached full feedings and IV therapy was discontinued on day of life 25, so the PIC was removed. However, on day of life 73, the infant had a bowel reanastomosis and the team had difficulty placing the peripheral IV for surgery. When the infant came back from surgery, they could not place PIVs. So an EPIV was placed in the left arm for continuous fluids while the feedings were gradually increased back to full volume. The EPIV provided vascular access for the entire feeding advancement and was not pulled until then, so it was a success. So the analysis of this is that although this infant was born at 27 weeks and had a successful UVC placement and PIC placement, the infant endured multiple venipunctures and for routine labs over the course of 73 days. The infant had multiple miscellaneous PIVs in those 73 days for other short-term treatments such as blood transfusions. Post-surgery, the EPIV provided the most optimal solution for this infant who developed difficult vascular access after his entire length of stay. The next infant I wanted to discuss is a 36-week gestation infant weighing 2450 grams with a prenatal diagnosis of abnormal kidney findings. On day of life 2, a nephrostomy tube was placed and polyuria occurred post-procedure and it required fluid replacement of IV fluids 1-to-1. An EPIV was placed on day of life 4, and due to this infant's need for continuous replacement fluid, it was up to 50 mLs an hour. On a baby, that's a lot of fluid. The EPIV worked, and it was pulled after 9 days of treatment, once the infant was stabilized. So the analysis of this patient is that this was a near-term infant with an unknown length of treatment based on the prenatal diagnosis. And that was most likely why a UVC was not placed initially. This infant did not require vesicant medications or nutrition, but required that really high infusion rate. The medical team did not want to risk placing a central line at this point, since the treatment the length of treatment was unsure, and they didn't want to risk the infant's eclampsia rate. So the EPIB provided that stable access for the short course of treatment. If a PIV was used for that at 50 mLs an hour, it would not have lasted 9 days. The last patient I want to discuss was a full-term 38-week infant who weighed 3,200 grams. This infant was evaluated for therapeutic hypothermia treatment after prenatal depression at birth. It was determined that the infant did not require therapeutic hypothermia. However, the infant did require respiratory support. The mom had known chorioamnionitis, and the baby had initial positive blood cultures and required 10 days of IV treatment. Difficult vascular access was noted, and this infant fell within our inclusion criteria for needing an EPIV. So we placed one on day of life 5. However, the EPIV migrated out 1 centimeter and was leaking at the insertion site after only 4 days. The catheter itself was not leaking, and it was not infiltrated. However, we did have some leaking backing up, so the EPIV was flushed and needed to be removed. So this infant was noted to be a diva. The EPIB was chosen for antibiotic treatment plan and was successfully placed. However, it did only provide 4 days of vascular access, but that's 4 more days than a peripheral IV. It did fail to remain in place for the entire course of treatment due to leaking and migration. And so we're going to talk a little bit later about what we're doing to try and prevent the leaking and migration. So now I'm going to turn it over to Nina, who's going to discuss the procedure and care of maintenance.
Hi, good morning. As far as the insertion procedure itself, this probably will seem basic to many of you, but we are going to go over it anyways. Basically, optimal sites for an EPIB, it can be placed in upper and lower extremities. The catheter tip should not terminate into central circulation or over joints. Suggested order of preference is the forearm, the leg, the scalp. We typically do place it in the forearm, but we have placed it in the leg. We haven't placed it in the scalp, but that's certainly something that we could potentially do if we needed to. So the actual insertion procedure itself is placed under sterile technique, but it's not considered a central line. It's used under Sellinger technique. The vessel is accessed with the 22-gauge angiocath or the needle from the EPIV kit, the actual introducing needle. The guide wire is the guide wire that comes in the EPIV kit itself. You need to use the guide wire from the actual kit. You can't use a regular MST wire because the guide wire needs to be a little thicker and rigid. Insertion procedure itself, basically this is just us accessing the vessel on a mannequin. Since the mannequin isn't going to move, we decided to use a mannequin for actual pictures. But basically it's the 22 angiocath or the introducing needle itself. Basically once you access the vessel, you're going to observe for a blood return, and then with the angiocath you're going to remove the needle, leave the cannula in place. Once you actually access the vessel, then you take the wire from the EPIV kit, gently insert it into the vessel itself, leaving the excess wire exposed. And then once the wire is actually in place, you're going to gently remove the angiocath over the wire, leaving the guide wire in place. Once you have the guide wire, then you gently take the EPIV catheter itself, sliding it all the way into the vessel. And as you advance the catheter itself, you want to hold onto the guide wire, because as you insert the catheter, you can actually advance the wire with the catheter. So we have noticed that that can happen. So you just want to hold the end of the wire as you're gently inserting the catheter itself, and then gently basically remove the guide wire, leaving the catheter in place. Once the catheter is actually in place, you'll see the blood return. It's basically just like putting in a peripheral IV. So you'll see the blood return coming out. You don't need to take an x-ray because it's not a central line. It's not going into central circulation. And then we did actually do a couple videos for you. So this is just accessing with the actual angiocath. It seems very dark. Sure. Do you want me to pause it all? Yeah, pause it. Oh, that's better. All right, then let me just rewind that. Okay. So basically, the angiocath going in, accessing the vessel. So because this is a neonatal patient, we still use the transilluminator because we can actually see the vessel with the transilluminator. We do have an ultrasound machine. We do use the ultrasound machine. We do have a learning curve that we're still working on with the ultrasound machine, but we do have it. We do try to use it. So as you can see, the vessel was accessed. The needle was removed, the wire was put in place. Now she's just taking the catheter out from over the wire. So as you can see, as she inserted into the skin, she kind of gently grabbed the wire in the back and pulled it back a little, and then sort of slid in the rest, you know, a little more, then pulled the wire back, because that wire will advance with that catheter. And then hopefully you get a ton of blood like this. So at this point, you can gently aspirate and then flush the line itself. So I do have a second video that I'm going to just try to pull up.
So the other video that we're going to show is using the actual needle that comes in the EPIP kit.
So here's the second video. So you can see, again, we did use the transilluminator, but you can see the vessel so clearly with it. Sorry, this is amateur photography. We just grabbed a friend. Here you go, start videoing with their phone. So you can see the vessel was accessed, the wire was placed. Now we're gently pulling the needle out over the wire. Lots of blood.
We have found that you have to wipe the wire off with a gauze after you pull off the needle over it, because it gets very sticky once you're trying to advance the EPIV catheter over it.
So that's basically the video, and then, you know, just the same as you normally would do. Obviously, put the end on, aspirate, and flush. So as far as care and maintenance, we do secure the transparent or impermeable dressing per central line hospital policy. We do change the dressing every 7 days, or if it becomes soiled or non-inclusive. You can use a chlorhexidine impregnated disc over the insertion site or a hemostatic disc per hospital protocol as well. Catheters can be remained in place up to 29 days. To prevent occlusion, we do run heparinized fluids if it's a baby who's just getting antibiotics for it. So if it's a KVO rate of 1 cc an hour, then we do run heparin through it. If it's a baby who's advancing up on feedings, then we don't run heparin through it. So it's really just if it's a KVO rate. We also do change the fluids per central line policy. And these are just pictures of sterile dressings that we actually do. So the one to the left is without the hemostatic disc, the one to the right has that stat sail disc over it. We do label it with a little sticker that says EPIV, just because they do look like a PICC line dressing as well. What we also did is we decided to have some just bedside information at the bedside for the nurses. We have a lot of travelers, we have a lot of newer staff nurses, and we were getting a lot of questions about it. We did kind of review it over, like when we did our yearly competencies, but if you're not doing them all the time, it's a new device, people end up with, they have a lot of questions. So basically, this is what we have at the bedside. It can be used for any patient who has difficult vascular access. It's placed under sterile technique, that it's 4 centimeters in length. It will decrease the number of IV sticks. There's less risk of a bloodstream infection. It has less risk of IV infiltration compared to a PIV. Less risk of mechanical and chemical phlebitis. Can be used in place for 29 days and also have continuous fluids infusing. We also just sort of measure the 4 centimeters and take a picture so we have an idea of where the end is, so then the nurse can see exactly where the tip of the catheter would end. So basically the benefits for the EPIV is, it's placed at the bedside by a nurse. Sorry, I didn't realize this was... So placed at the bedside by a nurse or a physician will decrease the number of IV sticks, which will also decrease painful procedures, because we don't want to cause any harm to our patients unnecessarily. Will decrease the need of a central line, decrease the risk of a bloodstream infection. There's less risk of infiltration compared to a PIV. Less risk of mechanical and chemical phlebitis. It can be used for 29 days. So those are all the benefits. And then complications. The first 3, not necessarily complications, but things that to keep in mind. You do need a vessel that will support a 2 French catheter. It will require continuous IV fluids if you're countering, that nutrition. Cannot be used for vesicant medications or central parenteral nutrition. And then certainly the leaking at the insertion site and line migration are complications. So what we've learned, for the patient population, the size of the baby really doesn't matter. It's really just the size of the vessel. To recognize these patients early because of vein depletion. As far as the patency management, we do need to run continuous IV fluids with the 1 cc an hour. We have had migration and leaking issues, so we've decided to use a securement device under the sterile dressing, which we're still we're doing that to, as just to be helpful. As far as the insertion site, we've been doing a hemostatic disc to try to just form a clot at the insertion site to prevent migration. And then future implications, we're just basically continuing to educate the physicians and the nurses on vein preservation. So they'll consult us earlier on putting the device in place. We're going to develop a vascular access algorithm just so they do consult us, and it just gives them the guidance of who should be having this device placed. We'd like to add criteria for the hypoglycemic admissions because, the babies that come in, they're on D10, they're on 12.5, but their sugars are sort of just getting by. So you're not going to be weaning over the next day or two. So this would be perfect for these patients because, they go through IVs quickly when their 12.5 is running. So as far as the leaking at the insertion site, we're sort of looking into that acrylate glue. We haven't started using it yet, but that's our sort of next step. We're thinking of doing a QI project because, it's all about the babies and getting that information out there, and also collaborating with PDSIG for the 1 Million Pokes campaign. These are some resources, and thank you.
Good morning. Linda and I are happy to be here to tell you about our experience with the LeaderFlex extended dwell catheter in the adult patient. Before we start, we have a few business items to take care of. One, we have been compensated to serve as speakers for this program. Secondly, we are providing general information on the catheter and not medical advice for any patient. Okay? It's just how we found the catheter to work for us in our institution. And thirdly, Linda and I are clinicians from Southwest Florida. We survived Hurricane Irma, but we're hoping to survive this. So it makes us a little nervous. We're not used to public speaking, okay? Bear with us. So as institutions across the country try to decrease their CLABSIs, and we know that CLABSIs cause many problems for our patients, increase their length of stay, hospitals pay more money, they have many untoward effects, as well as ultimately can end in death from a CLABSI. We knew as vascular nurses that we needed to help in any way we could and take any initiative we could to help decrease this problem. We also found that we were dealing with more vascularly challenged patients. So if your institution was like our institution many years ago, we disbanded our IV team and we relegated that task or skill to the floor nurse. And we know that they're not as skilled as vascular access nurses. And statistics show us that first-time success rates for their IV starts are not very high. So by the time we get a consult to come see the patient, they've been stuck and stuck and stuck, which leaves us less veins to choose from and harder to get into. We've also had an increase in IV drug abuse patients in our facility, and we know that they've used up every vein that they could possibly use before they get into the hospital, and that lets us have to look for deeper vessels. Makes it a little bit harder for us to get into. At our facility, we do place ultrasound peripheral lines, but we found that they don't last as long. And we think that that's because the catheter we use is stiff, causes a little trouble to that vessel, and it's not long enough to get into the vein that we're going for. And we know that we need to seat at least 50% of that IV catheter in that vessel to have good results. So our results are not so good as we would like to say they are. So with all that being said, we knew that we had to do something to help our patients. So our sales rep brought us this catheter a couple of years ago and asked us if we'd like to use it as a midline. We looked at it and said, well, no, we're not having any trouble with the midline we use, but this is a nice looking catheter. This could fill that little niche that we need for those longer peripheral IV lines, and it's softer, easy to insert, so we thought, we might have something here. So we decided to ask our boss if we could do a trial on this catheter, and she was like, well, does anyone else use it this way? And we're like, no, but we want to be the first. We want to be out there in the beginning and see if we can do better for our patients and get one needle stick for them on a peripheral start and let it stay in for as long as it could dwell, up to 29 days. So after much to do and getting our infection control department involved, because of course they want to decrease CLABSIs, and our infectious disease department, who's all over CLABSIs, we got the permission to start a trial. But before we started the trial, we decided that we needed to change the name of this catheter because it's a midline. And our floor nurses would be confused if we said, today we're placing a midline here and tomorrow we're placing a midline here. So in order to cut down on confusion, we decided to call it an extended dwell peripheral catheter in our institution. So we call it an extended dwell. So we got everyone's blessing and we started a 3-month trial. Before we go into that, I'm going to let Linda tell you a little bit about the catheter.
So I'd like to review one of the standards that we as vascular access nurses follow, and that's the Ils Guidelines, that states that the catheter selected shall be of the smallest gauge and length, with the fewest number of lumens, and shall be the least invasive device needed to accommodate and manage the prescribed therapy. And that is why we chose the extended dwell catheter, or LeaderFlex. So LeaderFlex was used in Europe for many years as a pediatric catheter, an arterial catheter, and also as a midline. It's used here in the United States in adults and pediatrics, mostly as a midline, so below or above the antecubital fossa. At our facility, we decided to use it below the antecubital fossa. It is a 22 gauge catheter, so it's a small catheter, and this allows for increased hemodilution in the vessel. It comes in 3 different sizes, or lengths, 4, 6, and 8 centimeters. It is a polyurethane midline catheter, so it is a nice soft catheter. There is no dilator, so it reduces trauma to the vein because we use modified Seldinger to place it.
So as we said, we got the permission to start a 3-month trial, but before we started our trial, we had to decide if we were going to be able to discharge patients with the line, because extended care facilities and home health would know nothing about this line and how to care for it. So of course the powers that be at our institution said absolutely not. So we had to find patients that were going to be in the hospital for long term, which we all know is hard to find because they want to get in, they want to get out, they don't want to stay in for a long time. So that was one of the limitations on our trial. But we did find some patients that were in our hospital for a little bit of time, mostly, unfortunately, our IV drug use patients who are with us for quite a long time. We had another issue with the little bit of a learning curve when we first started with the catheter, as well as the needle that we first used. We didn't think was as sharp or echogenic, but have since changed that needle and are very happy with it. So we placed 79 catheters in 3 months. In March, we placed 19 catheters. And we started with the 6 and 8 length because we didn't know, it was new to us. We thought, well, let's try it. We'll put them in the lower arm and see what happened. 11 of those patients made it to end of treatment. And it was hard because if they were going home, we had to take it out. But still, we had good results, but our dwell time was only 4 days. We thought, well, that's really not much better than a peripheral, so what's the deal here? So we talked about it as a team, and we thought maybe we should be placing the shorter length catheters. So of course we called Vygon, and they were very happy to send us a box of the 4 centimeter catheters. And in April we placed a mix of 4 centimeter and 6 centimeter catheters. 23 of those patients made it to end of treatment with a slight increase in our dwell time of 5 days, but we noted that those were on those shorter catheters. So in May and June we placed all 4 centimeter catheters. 22 were placed in that time period. 12 made it to end of treatment. As you can see, our dwell time went up to 10 days. So we knew we were onto something. So we took all the information back to our director and our infection control and infection disease departments, and they were happy with the results because we were telling them that this catheter was going to save veins, it was going to allow us to get central lines out sooner, and it was going to allow us to not put in so many PICC lines or midlines if the patient really didn't need it. So we were preserving vessels in the upper arm and in the lower arm. So it took about 2 months for our hospital to get everything set up because we made a custom kit. And in that 2-month period, we had patients that had had the line that came back in the hospital and said, I want one of those lines. Why can't I have one now? It worked great when I was here and it was comfortable. And we said, sorry, we're waiting for the product to come. The nurses weren't happy. I actually even had an infectious disease doctor stop me in the hallway and say, do you have those catheters in yet? And I said, not yet. He said, here's my cell phone number. Call me when you get those in because we really want to use them. He knew that they were a great benefit for his patient. So October was our first month of full use post-trial. We placed 73 catheters that month. 53 of those catheters made it to end of treatment with our average dwell time of 15 days. So 1 stick in the lower arm, preservation of both vessels in the lower arm because now the floor nurses aren't sticking them and sticking them, and preserving that upper arm vessel for if the patient needed a dialysis catheter or if they did need 42 days of treatment, and we still had those veins to use.
So again, the benefits of the LeaderFlex catheter, it's polyurethane, it is not Teflon, so this causes less trauma to the vein. We place it using modified Seldinger, so there's no dilator, so it is easy to insert, less trauma. And vein preservation, that is our goal. And by preserving those lower arms and those upper arm vessels, so when they are needed, we have them. There's more vascular choices in the lower arm. The length of dwell time, 29 days is our goal. You can take blood pressures in the same arm and access lab draws, so you don't have to limit the use of that arm that has the extended dwell catheter. We can place more than 1 catheter in the same arm. So these patients that are in intensive care and they or trauma patient only have 1 arm, then we can put 2 catheters in the same arm. Patient satisfaction. So anytime a patient doesn't have to be stuck multiple times, of course you're going to see your HCAP scores go up. So this is a big plus. It reduces the delay in the treatment. We work as a team, so we work into, at our facility we are very fortunate. And for this procedure, if we have 2 people, it takes us about 10 minutes to place the catheter. If it's just 1 person, 20 minutes max. So this reduces the delay in treatment. And it is a revenue-generated procedure. So this helps us get more FTEs. We actually increased our team by 2 vascular access nurses. So that's a big plus.
So we took some snapshots of our data. This slide will show all medicines except vancomycin. The next slide will be vancomycin. Just as a side note, we have an other category there. Unfortunately, we had, and still do have, a little problem with clotting, but we relate that to the connector cap that we're using, and if your facility, again, is like ours, it takes forever to make a change. So we're in the process of trying to make a change so that we don't have so much of an issue with clotting. The other column also encompasses patients pulling out lines, which we know they do, and unfortunately some nurses pulling out lines because they were thinking that the site needed to be rotated. So it was challenging, but we still have great results. This is a snapshot of 324 patients in the non-vancomycin graft here. Let me just make a side note. We did put lines in for patients for only 1 or 2 days. If by the time we got there, that's all that was left, and we had no vein choices otherwise. So that made our numbers a little bit skewed because it was still a success, but it was only 1 or 2 days. Whereas no one else could get a line. Someone had tried an ultrasound, someone had tried everything. They couldn't get a line, so we placed this line, even for 1 or 2 days. So in the 1 to 5 day category, 157 of 228 patients were end of treatment or discharged with their line. In the 6 to 11 days, 49 of 64 patients made it to end of treatment or were discharged with their line. So now here's where we get the big benefits. The 12 to 17 days, 14 of 21 patients completed their therapy with 1 needle stick, 12 to 17 days. 5 of 6 patients made it 18 to 22 days, and 5 of 5 patients completed therapy, 1 needle stick, 23 to 29 days. These patients were happy. So it is definitely a nice catheter. On the next slide, which is our vancomycin slide, the number was smaller, but this could be vancomycin alone, or it could have been vancomycin with other antibiotics. It was too much to separate every one out, but if they had vancomycin, they were included in this graft. And we know that vancomycin is still tough on the vein, no matter what the standard says. If the patient's going to get 42 days of antibiotics, they probably still need a PICC line. But there are exceptions to the rule, and we have found some. In our vancomycin graft, the 1 to 5 days, 31 of 67 patients went 1 to 5 days with vancomycin. And these patients were telling us that before we got there, that they were being stuck every day or twice a day for an IV for their dose of vancomycin. So still, we believe that that was a success. In the 6 to 11 day category, we had 16 of 34 patients make it to end of treatment or discharged. The 12 to 17 days, 3 of 8. In the 18 to 22 days, 1 of 1 patient. And again, in the 23 to 29 patients, we had 2 of 3 patients complete vancomycin therapy with 1 needle stick. You do still have to monitor the lines. We do check our lines every day, and you have to make sure that everything is good. Sometimes we'll even ultrasound the vessel to make sure the vessel still looks good, but it is working for us. A lot of those patients were, again, our IV drug patients who we didn't want to put central lines in because they're still active drug-seeking patients, and a lot of them still manipulate their lines. So in order not to have a collapse from them or any issues, our docs said, let's try this. So we did, and it works. And during the time of this snapshot, we had 2 patients that had their lines placed, were discharged, went to an extended care facility, and a week later came back still with their extended dwell catheter functioning with blood return, stayed in our hospital another 2 or 3 days, and we sent them back out to the facility with the same line. So everyone in our facility is very happy. The next graph is just a snapshot of our data from November to April. This is 443 patients. And if you look at the orange and red, you see that 83% of our patients with the extended dwell were discharged or completed therapy. The yellow is the clotting issue, which we have a 10%, which we're working on. And the 7% is the other category, where you still do get a phlebitis every once in a while. You still do get an infiltration, and you still get the patients pulling lines out. But on the whole, it's much better than just a peripheral line. And I'm not trying to tell you that this is the end-all of IV therapy. This is going to solve every problem, but it sure is going to help. It really is. And I'm sure we're all familiar with Dr. Chopra. He's actually one of our speakers here at AVA, I think, this year. And he and his partners authored the MAGIC study. But he also says that 1 billion IVs are placed per year. And it's the most common procedure for patients. And sometimes I think we take that for granted. Oh, it's just an IV start. But it's more than just an IV start, especially to those patients who are getting stuck over and over again. He says with increased PICC usage, which was what we see all the time, if you can't get a line in, put a PICC in, you have increased complications. So the best way to decrease those complications is not to have a PICC line in the first place. There are other choices. And we, at our institution, consider ourselves a thinking PICC team. We may get an order from a doctor that says place a PICC line. we will evaluate each patient, and then if we don't feel that that's the best line or the patient can benefit from an extended dwell, we contact the doctors ourselves and we talk with them. And most of the time they're really good about taking our advice. We still have some of the old school docs that say, ordered a PICC line, put in a PICC line. So in that case, it's just going to take time, I think, before we can get all those people to see that the best way is just to consult the vascular access nurse and let her evaluate the patient, see what meds you're on, and place the most appropriate line.
So this is a graph of our PICCs, midlines, and our extended dwell catheters that we place at our facility. We are an 800-bed facility, and we just became a number 2 trauma hospital, so we keep very busy. So as you can see, this is the beginning of our trial here, but this is us now. So by decreasing our PICC usage and increasing our extended dwell catheter use, we have decreased our central line and peripheral bloodstream infections.
So as Linda said, we had an issue with our bloodstream infections, and that's one of the reasons why our hospital was so anxious for us to try and do what we could to help solve this problem. And unfortunately, I'm sad to say that in 2015, we had 20 CLABSIs. And we also had 12 peripheral bloodstream infections. And I've been a vascular nurse for a long time, and when we had dedicated IV teams, I never remember seeing peripheral bloodstream infections like we see them now, as well as peripheral DVTs. That was unheard of before. But we see those now because we don't have the skill at the bedside. And I'm not trying to downplay any nurse. I'm just saying that we do need dedicated teams. So with the use of our extended dwell catheter, getting the central lines out quicker, placing these lines, and also rounding on all of our lines every day, in 2016 we decreased our bloodstream infections from 20 to 5 and our peripheral bloodstream infections from 12 to 4. And we are still in that downward trend, so we're hoping to be at 0, which I think we're pretty close in our next reporting report. So it has worked for us. So Linda's going to tell you a little more.
So the types of patients that would benefit from a leader flex, any patient that is a difficult IV stick, patients with compromised vasculature. This includes our dialysis patients, our mastectomy patients, IV drug abuse patients, and our trauma patients that are only limited to one arm. This reduces the need for PICC and midline catheters. It facilitates early removal of central lines. Our intensive care unit is trying to get their IJs that we know the dressings do not stay on and they are compromised. So we try to get those lines out as quickly as we can. So we get evaluations from our intensivists and our ICU nurses to place the extended dwell catheter while they're in ICU. That way when they transfer out, they can take the IJ out and they have the extended dwell until they don't need it anymore, they're discharged. Patients with positive blood cultures. These are our IV drug abuse patients and our oncology patients, sepsis patients. When they have positive blood cultures, of course, we don't want to put a central line in. So we place the extended dwell catheter. On the patients with endocarditis, we know they're going to need 42 days of treatment. Not always vancomycin. So by putting an extended dwell catheter in, I last them 14 days until their cultures come back negative. If they need vancomycin, then yes, we will put a PICC line in. If not, sometimes the extended dwell catheter is all they need. We actually had a patient that was an IV drug abuser, had positive blood cultures, was getting stuck frequently. We got the evaluation after 11 days. We placed an extended dwell catheter. It lasted 29 days. He needed 3 more days of treatment, We actually got an order to leave the extended dwell catheter in. He made it to the end of treatment without any more IV sticks. Vein preservation, of course, that is our goal for upper and lower vessels. Reduction in repeated veni punctures. By doing the extended dwell catheter, we decrease the amount of times the patient gets stuck. And 29 dwell time is our goal. But if the extended dwell catheter, or even 14 days, for the patient not to get stuck again, we think that's a success. So we were fortunate enough to have one of our coworkers volunteer to be our patient, and as you can see, he had a beautiful vein that we could access. As Mary said, we do have a custom kit that we use. We do pre-prep with our chlorhexidine, our sage, and then we do a mini barrier, and we have a fenestrated drape. So as you can see, I am accessing his vein, and you can see the needle there. Now with this catheter, as with peripheral IV, ultrasound IVs, you kind of have to walk the needle. With this, as soon as you get a blood return, that's when you know you're in the vein, and then you can thread your wire. There I am threading the wire, and I'll be removing the needle, threading the catheter. And it does really slide right in. Now as far as care and maintenance, we use a grip lock, a pediatric grip lock, and it has the cutout for the wings. We use a bio patch and a transparent dressing. We change our dressings every 7 days and our connectors every 7 days. As Mary said, we round on our patients with extended dwell catheter every morning, so we keep track of our extended dwells just like our PICC lines and our midlines.
So during this time, we've had many patients tell us that it's just been a benefit. There are a few patients that stand out in our mind that we'd like to share their experience with you. We had one patient at the beginning of our trial come into the hospital, and he needed surgery. He was on Coumadin at home, needed to be bridged over to heparin. So he was in the hospital for a couple days, and then we got a consult from the floor to come and evaluate him because they couldn't find any more veins. So I walked in his room and he said, "Oh no, not another needle stick. I've been here 2 days and I've been stuck 10 times. Look at my arms. They were bruised from the top to the bottom." He was not happy. But I did say, "Wow, do I have a catheter for you?" So I told him about the catheter, and he was very happy to let us place the catheter. We placed the catheter. He stayed another 10 days. No needle sticks, completed his therapy, and upon discharge, found our office, came looking for us to say, "I want you to look at my arms. I don't have a bruise anymore. This is the best thing that has happened to me since I've been in this hospital." So he said, "If I ever come back, I'm going to ask for one of these." And I said, "Well, you know, we're not here 24/7. We're only here 6 to 6. He goes, "That's okay, I'll wait." I said, "No, you can't wait." But he was so happy. And we do have a lot of those patients tell us that.
We also had an employee, registered nurse, that ended up having surgery. She was inpatient for 2 weeks of IV antibiotics. So they gave her an option, a PICC line, midline, or an extended dwell catheter. Of course, she picked the extended dwell catheter. Had her 2 weeks of antibiotics, was discharged. Of course, if anything's going to happen, it happens to a nurse. Developed some complications, had to have 2 more weeks of outpatient IV antibiotics. Again, she chose to have another extended dwell catheter. Made her 2 weeks of treatment and was very happy with this catheter. And she said if she had to have it again, if the need became, she would definitely pick this catheter.
We also had a patient who was a dialysis patient who came into the hospital, and she said, that she was definitely a hard stick. And we said, yes, we can see that. And she didn't know how long she was going to be in, so we placed the extended dwell on her. She ended up having to have her toes amputated, so she was with us for quite a while. And she had her extended dwell catheter in, and she transferred to our inpatient rehab so we could follow her there. So she had 29 days. This was in the beginning before we thought, oh, maybe we can leave it in longer, but she made it to 29 days. We took that one out and placed another one. She made 14 more days with 2 needle sticks on a dialysis patient. That lady was jumping for joy. She said that has never happened before. And again, I had a PICC line at one time, and if I had a choice, I would have chosen this, but it wasn't there at the time. I would stay out of someone's SVC, decrease complications, DVTs, everything else. If you can, stay away from it. Use other means. So basically that's the end of our presentation. We just want you to know that every patient deserves optimal vascular access. So we would ask you just to consider all options before you choose a line. And this is now another option that could be available to use at your facility. Thank you.
Thank you so much to our speakers. I think the one thing that stood out for me as a vascular access specialist is, all devices do fail. At Brigham's, you said you had to remove a PICC because you got an infection. That catheter failed that patient. I don't think there's a fail-safe product on the market that will meet every patient's needs and get them all the way to therapy all the time. So it is just something to think about. It's another tool in our toolbox for our patients with good assessment of the vasculature and considering the history of devices and what the prescribed therapy is. We'd like to take some questions. We do have a microphone up here if you'd like to ask the panel any questions.
Good morning. This question is for Jess and Nina. Do you routinely infuse heparin into your normal, regular PIVs?
Can you hear me with this? If it's at a KBO rate, if the EPIV is only used for IV antibiotics, we do some heparin with the KBO rate at 1 an hour. If the infant is receiving, their whole fluid volume and the antibiotic and medication through it, then we don't add heparin to it. It's only when we get down below to the 1 ml an hour.
What about your regular IVs?
I'm sorry, I didn't hear you.
What about your regular IVs?
Our regular IVs, no, we do not add heparin to them.
Go ahead.
Hi, on the adult patient, the leader flex, can it be saline locked off, should it be heparin locked, or do you run KBO?
So we treat it just like a midline. 10 cc's normal saline flush, and we do not heparinize.
And how often do you flush it?
Depends on if they are getting medication or not, or if they have continuous fluids.
Okay.
So once a shift.
Does it come in any larger size than the 22 gauge?
It does not.
It does not?
It doesn't.
Okay.
And we have to remember, it is a peripheral cannula. There is, as we all know, we do things a little different at every organization. So we do have some hospitals that run continuous where others do saline lock it. I think what we know, what will lead to success with just saline locking is knowing your end cap. Because if we have neutral, there's the clamping sequence. Positive, we have a clamping sequence. And when we don't have a clamping sequence or we have a cap with a valve, we can kind of negate some of those occlusions.
Okay, and last question, can you draw blood through these?
My
routinely?
question, I guess, would be, do you draw blood from your current 22 gauges? And sometimes we do, and we know the risk is potentially clotting the catheter. So I think we have to assess that moment in time with that particular patient. People are drawing blood, nurses are drawing blood off of it.
My question is for the NICU folks. Do you ever infuse blood through them?
We do. We treat it just like a regular peripheral IV.
That's awesome.
Never have. I don't think we have them, sorry.
It would.
We have in the adult patient.
Yes, because again, it is, in the NICU, many times we do give blood through a 24 gauge, so it is completely appropriate to give blood through a 22 gauge. This is a little longer. Anytime we infuse blood, there is a risk for occlusion, so that wouldn't change with the leader flex.
Yep.
I have a quick question. So you guys don't use, it's the modified Seldinger technique, and I thought that had to be a full sterile drape barrier when you do that.
It's actually Seldinger technique to place the device.
Right.
And given that it can dwell for up to 29 days, you know, as a clinician, and I recommend to Vygon that is something that we recommend for this device too. We don't report short peripheral cannula infections, but it doesn't, you know, we should take all the precautions to prevent one.
So when you guys have a kit, is it a full barrier drape kit?
Hat mask, sterile gloves, and a fenestrated drape, or like in the NICU, the blue towels, because you're working with a smaller area.
So it's not the full drape that they
Not
recommend?
a full drape or gown. Or you guys are using full drape and
In the
gown?
NICU, we do a full drape.
Okay.
We do a
Because that's
full
the way,
sterile
my
technique.
understanding, it should be that way, but if you're doing this Seldinger technique.
You're doing Seldinger, you do have a wire, so there's potential contamination of the wire, so I think you know, take that into consideration. I think more is better, and we should be using all the precautions that are available.
Thank you.
I have a question for both sides. For the adult, do you get nephrology clearance for these catheters since you're in the forearm?
Is this working?
Yeah.
Nephrology is on board with us, and usually they'll tell us which arm to use, and it's
Or
being
you
placed
only have one arm.
in the lower arm, right, of the opposite fistula side, so that we're still preserving that upper arm vessel if something should go wrong with their current fistula or graft, that they would need another one.
Okay, thank you. And then the NICU girls, how long is the wire, the guide wire? Because you're concerned with it advancing. Just wondering how long is that wire?
It's like 20 centimeters. It's pretty long, you know, and with only a 4 centimeter, and because the limb is so short, you know, when you kind of grab the catheter, the wire comes too. So that's why we kind of do like a push and pull.
And one of the ways to manage that too is with Seldinger, once the wire is in the patient and you're threading the catheter over, I like to hold the wire and just put my hand down. So as I'm pushing it off of the wire, I'm not pushing the wire in the patient. But eventually, and I think you guys can agree, the more you do, it's almost a push-pull simultaneously.
So since you're not using a full max barrier when you're inserting, are you using lidocaine for the insertion?
No, we treat it just like a peripheral, and we don't use lidocaine for our peripherals, so no.
You've had no real issues with that as well. And have you had any issues with the wire without using the full max barrier off the sterile cable?
No, because our fenestrated drape is big enough. We have an under drape, a fenestrated drape, we sleeve our probe. So it's almost like everything we take for our PIC or midline. We do a pre-scrub, we do a scrub, all those things. So
Just no max barrier?
correct.
Thank you.
Hi, good morning. Nice presentation. I just have a question. The midline, you call it extended dwell. Now they're selling extended dwell in midlines, like, you know, there's separate entities. You're tagging your midlines into PIV. I mean, you change them. Is there a legal, possible legal
No, I think the things we have to remember, you know, a midline is a peripheral device. A short peripheral is a peripheral device. This is considered an extended dwell, and I wish Lynn might have been here this morning because we talk about that. It's a manufacturer name to let you know that it can dwell longer. So midlines are placed in the upper arm, tip terminating in the axillary vein, versus in the lower arm, like your short cannulas. But again, it can just last longer. So the medications and how we treat it, like Mary said, would all be the same because it's a peripheral catheter, it's just longer.
Yeah, I get that. It shows I thought if it's the midline, like if it's a PIC line, you cannot cut it to make it a midline.
Right.
The tag is midline,
Yes.
I mean a PIC. I'm just trying to understand.
Yeah, it's
the
such a
legal
short
implications.
catheter that we don't cut it. It comes in the size, the length that we need.
And that's why it comes in a variety of sizes as well, because it is used in the NICU, pediatrics, and adults. So if we're placing it upper arm, tip in the axillary, we'd call it a midline. But lower arm, that extended dwell, peripheral.
Thank you.
You're welcome.
Hi. We're in the very beginning stages of being trained to place ultrasound-guided peripheral IVs at our hospital, and this sounds like a better idea to me. Do you pay attention to the catheter vein ratio in the lower arm? Because I've looked in the lower arms and those veins are small. So do you have a catheter vein ratio?
We do not for the lower arms. Of course, when we're doing our PICs, we are measuring now. A lot of these patients do have some good vessels in the lower arm. We do have some of those that are, you know, very small. But I think with us becoming more familiar with this catheter, we still have a good success rate with them.
Great, thank you.
My opinion would be to use it instead of an peripheral ultrasound because it's much softer, goes in very easily. That's our goal actually, to just try and start all of our lines with this type of catheter, but we're such a busy team, we have trouble getting to do all that. So hopefully now that we've added 2 more people, we'll be able to address some of that. So if you imagine we put 99 lines in this past month without being able to see these patients on the first stick or when they first come in the hospital, that number could go way up.
When I hear someone talk about running vancomycin over 8 to 14 days, it makes me cringe. So I just wonder what your thoughts were with the MAGIC guidelines, and are you seeing any problems with that? And just because we can do something, should we do it?
Well, yes. Just because we can, we don't always do it. But if the patient, we try to just do it for patients that are a week or 10 days, and then we monitor the lines. If it's going to be long-term, we try to get that PIC line. But again, there are sometimes cases where you can't get a PIC line in, and you can't get an IJ or whatever the reasons are, and so we're left with this as an option, and it has worked. We try not to ever send a patient home with a line that's going to get vancomycin for any length of time because they won't know how to monitor it for problems. It's mostly for our patients that are in-house, our long-term patients. So, and we, again, try not to use them for that long, but we do, and we'll monitor them. We look at them every day.
I think we all had concerns about vancomycin because we were taught that for many years that if they're on vanco, they need to have a central line. So it is a little bit of we got to let go of. But the pH still remains the same. It's 2.5, but it's a 22 gauge. The leader flex is. So hopefully we're getting good hemodilution around the catheter. So versus a 20. Or an 18 in some cases, and getting that irritation right on the vessel wall. So it's probably why we're seeing better results.
Hi, I have a question for the NICU team. So since it's only a 22 gauge, are you still able to do it in the lower forearm? Because I've noticed your video was all the upper arm, and do you only use just that one size, or do you guys use longer?
So we always use the 4 centimeter, and we typically place them in the forearm. So the video, it was a little deceiving on one of them. It is actually, I like to try and place them down here, because we don't want the tip to terminate in the midline area, because then our docs like to call them midlines, and we don't like to do that.
So then if you did it in the leg, would you use a longer or just use the 4?
Not necessarily. We would still use the 4 centimeter, but we would, kind of just go like mid-calf.
And can you also draw blood with the neonates as well?
So the smallest catheter that we typically draw blood from is a 2.9, so 2.6.
2.6.
Yeah, it's a 2.6 French, and this is a 2 French.
So no, you don't.
So no, we don't.
Okay.
I have several questions for the adult people. Are you using any longer ones for like the really obese people?
Yes, we are. We've actually had really good results using 6 centimeter catheters on our bariatric or morbidly obese patients. We actually had a surgeon that wants us to place the extended dwell catheter before their surgery. They send them home with the extended dwell catheter in case they develop any complications and need fluids. That way they don't get stuck again. So they leave it in for a week, and if they don't need it, they take it out after a week. But yes, they do go home. And 6 centimeters definitely, because of the depth.
Okay, so the results you showed, does that incorporate all the different lengths, when you were...
Yeah, we haven't placed many of the 8s. We were using those only if we couldn't find anything in the lower arm and we needed to use an upper arm vessel, we would use the cephalic. So then we're still preserving the basilic and the veins for PIC or midline, and then we would use a longer catheter up there.
Okay. And when you were saying that some of the doctors are asking for these, are they placing an order for that, or is this just
At our facility, we don't really need an order. We wrote our policy so that it can be a nurse-generated option, but we do have doctors that it's in our system, and so they will place an order, and most of the time it's our infectious disease doctors. They're going to send their patient home with whatever, 5 days, 7 days of meds. They just say, place the extended dwell and discharge. So we do get a lot of consults for that, and our hospitalists and our intensivists, they like them as well, so they'll consult us to come over and see if they have vessels before we pull the central line.
And then for the dressing changes, do you guys change them? Or
We do. We change the dressings on all of our lines.
Okay.
Okay.
Thanks.
I don't know if this question's been asked before, but is it power injectable?
It's not power injectable. If your patients are going to need power injection, they would need a power injectable device, if that's why they're calling you. I think what we know is only 5% of patients actually get power injection through a power injectable device. So if you're being called because they need power injection, you'd need to put in a device.
We just wonder, because like where I work at my institution, it's in oncology, and they do a lot of scans, PET scans, whatever, CT scans, things like that. So,
Yes.
Okay.
I know in our hospital, it seems like we get called after all those things have occurred, and we were actually able to reduce costs and put in non-power injectable devices for the patients who already had their diagnostics done.
Thank you.
Is anyone using this in the EJ?
It can be used in an EJ. They haven't placed it. Would be a great option for the EJ.
From a billing perspective, how do you charge post for this procedure where it is a cylinder technique?
And it would be on an outpatient and an inpatient situation.
We actually take a picture and they charge for the ultrasound, and then they charge for the catheter.
Okay, so just the supply on the catheter, or is there a procedural cost like there is with a PIC line placement?
It's all built in. I mean, I think it's comparable to a midline. Well, maybe not. It's probably half the cost of what a midline or
Okay.
PICC line costs.
So are your charges at your facility from a midline to a PICC line different?
No.
They're the same?
They're the
correct?
same.
So then this procedure, you're saying it would be half?
It's about half. They
About
bill
half.
about half, yeah. So they were smiling.
Sure. Okay, thank you.
Yes, the cost of the supplies are less, but some organizations are charging for midline placement under the PICC code.
I'm sorry, one more question.
Have you used these on bone marrow transplant patients at all? I'm getting a lot of pushback where I work that they don't even want to leave a peripheral in more than 4 days, even though it's perfectly fine.
No, we haven't at our facility. We have a Moffitt, which is up the road from us, so a lot of our patients like that are up there. So we haven't, but there was interest. We did a seminar down at our own hospital, and Moffitt was interested in it, so maybe they'll start using it.
All right. Well, wonderful. Thank you for all the questions. If you have other questions for the panel, I'm sure they're happy to answer them. But again, thank you so much for attending the breakfast and enjoy the conference.
Thank you for letting me use your chair.
Hey, no problem.
When I saw you get up, I said, oh, I've got to rest my arm for a second.
That's so funny.